good evening and welcome everyone. We are so excited to launch this brand new program, and I am here with Dr. Clay Hoberman, and he works and his specialty is hospice and works with St. Croix, correct?
Correct.
And I also have Dr. Geetha Palaniappan.
Yes.
I'm sorry, I knew I would butcher it. I even have it, but Palaniappan. We're just going to say Dr. Geetha, if that's okay with you.
That's okay.
And so with Nebraska Cancer Specialist and in oncology, specializing really a lot in breast cancer,
Yes.
focusing with that. So we're so grateful to have both of these professionals with us tonight. And Dr. Clay Hoberman will go through the exciting details about the program that's brand new. But I want to cover a few things for everyone. So this is a two-way conversation. So it is a conversation. It is not meant to be super medical. It's not meant to be, although we will be providing information, but it is just a comfortable chat to give you guys information about the important topic and have the bold and brave conversation. So you have the ability to raise your hand if you have a question. If you choose to raise your hand for that question, we'll turn your video and audio on when we go to ask questions. Instead of waiting until the end, we are going to prompt for questions at the end of certain segments as we move along the evening. Also, if you prefer not your video to be on, just go to the chat room and ask your question, and we'll make sure to answer that and get through those as well. So without further ado, Dr. Clay Hoberman, can you kick us off, please, and tell us about this great program?
Thanks, Cynthia. Welcome everybody who's logged online, and welcome, Dr. Geetha. Thank you for joining us. Your expertise and experience is going to be invaluable as we go through this conversation. So I just want to introduce this new program that Cynthia mentioned, which tonight is the first of, and it's really it's a new program. It's conversations that are focused on having hard, honest conversations, and they're conversations about breast cancer. They're conversations about treatment and about disease progression, and also about the end of life. They're hard conversations, but they're conversations that very much matter. And so, as an organization, Pinked, we knew that there was a gap in the services that the community provides to support survivors, and so that's where this program grew out of that, and really it meets our mission, right, from supporting people from diagnosis through the end of life. And so this is a 12-part series. It's going to span over 12 months. And we're going to cover lots and lots of topics. And like Cynthia said, ideally, these are conversations. They're back and forth between who's sitting here and you guys at home. So I think a couple of things that we would like to keep in the front of the mind is about providing information and about providing knowledge. It's about viewing each other in a holistic manner. It's about recognizing that people are not defined by disease and diagnoses. And most importantly, it's about empowering survivors to be able to make decisions that are right for them. And so I think with that, we'll kind of introduce topic number one, which is diagnosis. So we're going to talk about diagnosis from an oncological perspective, from a palliative care perspective, from a survivor perspective, and really with the goal of trying to demystify the language, to unpack some of the medical jargon and all of the information that's coming at us on diagnosis. So I think we'll cover diagnosis, we'll try to cover disease trajectory, we'll talk a little bit about prognosis, and then try to wrap up the evening talking about goals of care and what that means and how to define that. So I think with that, we'll kind of go, Dr. Geetha, to you first, and really we're just going to talk a little bit about diagnosis, right? And I think if we could just start at a bird's eye view, really, and talk about even the basics of what is cancer, right? And kind of unpack that for people. Talk a little bit about what breast cancer is specifically, and then we'll kind of see where that leads us, and we'll go from there.
Yeah, sure. Thank you everyone for logging in, and thank you, Cynthia, and thank you, Dr. Hoberman. Cancer is a very common disease for women and men as well. Our body goes through a lot of cell cycle. We have trillions of cells in our body, and these cells grow, divide, die, and new cells form. There's a cell cycle that is constantly happening in our body. For some reason, we do not know exactly why there are certain groups of cells become rogue, basically, and instead of going through this orderly process of cell dividing, dying, old cells dying, new cells forming, somewhere along those process there is a DNA break, and these cells suddenly become rogue and start multiplying much more faster than they would normally do. And once they start multiplying faster, they also has a tendency to spread from one part of the body to the other. And this is very unique to cancer cells. Normal cells do not do that. And that is why cancer causes so much destruction, not because it starts in one organ, but because it has a tendency to jump from one part of the body to the other. And they are very tricky in that sense. They are able to evade the immune system, and that's why they are able to trick to make sure that the immune system is protecting them instead of normally the immune system takes care of these cells. So these cells have an ability to infiltrate into the other organs. They have an ability to spread from one part of the body to the other, and they're able to form new blood vessels. Thereby, they are able to go to a different organ and generate new blood vessels to feed them and kind of destroy that organ in that process. So they keep destroying from one organ to the other, and that's why it causes destruction. And breast cancer is the most common cancer for women, and it starts in the breast, of course. And usually it can start in the milk ducts or in the breast lobules, and they have a tendency to go through the lymph circulation or through the blood circulation to other parts of the body. And so typically we see them as a breast mass or as a screening mammogram, very early cases, but sometimes they can be diagnosed as stage 4 even at the get-go. Around 5% of the cancers are diagnosed as stage 4 as the initial diagnosis. So that's in a nutshell about what is cancer and why cancer is becoming more difficult to treat.
I think that 5% number is shocking. I didn't know that. So 5% of diagnoses is
They're presenting as stage 4 cancer.
As stage 4 cancer. Wow, that's a pretty high number.
And stage 4, probably most people are familiar with the term, but I think we're going to get into really what staging means and what is 1, 2, 3, 4 and how to interpret that a little bit. But I wrote a little note that maybe we probably can all speak to, but the hazards of Googling your diagnosis and trying to self-diagnose and to really dig into the information without anybody to translate that, and certainly without knowing what the source is. I see it all the time. You probably see it all the time, right? It's an attempt to empower ourselves, but certainly can lead us down a path that is not productive.
Yeah, I think in this day and age, I think most people Google information. It is interesting that some of the studies are available online as Google information. So when I have to show my patients a New England Journal article, sometimes some of them are available free. So instead of using my username and password and logging in when I'm sitting in front of the patient's room, I go to Google and pull any JM article. The only advantage I have is I know the article name, I know which journal it is, and then I pull an APT trial saying that this is a HER2 positive breast cancer new journal, and I'm showing this to the patient and pulling that article and helping that patient.
Yep.
However, I have the advantage of me doing that is the medical background and able to understand what is relevant and what is not relevant and understanding the nuances. I do think to some extent it helps the patient to understand, to ask the questions so that they are able to gather some information and they are able to ask the right kind of questions to the oncologist and get the information. But to totally, completely believe everything available on the net, it may not be in their best interest.
Good.
But it does empower them to ask the right questions. Why not use this drug? I read somewhere like this. And half of my conversations sometimes ends up having those conversations of why can't you use this drug? I read somewhere that this can be useful. Well, that applies to this type of cancer, whereas you have this type of cancer,
Sure.
so this does not apply.
Good.
So
Good.
it does help them to bring up questions. And
Useful information, sometimes dangerous information.
sometimes dangerous, and I also
and-
think they just have to use it as a tool to ask questions
Good.
and clarify.
Anything you want to add to that?
No, I think that guilty as charged, right? Like, especially the first time around. The first time around, you're trying to get just every piece of information that you can get in order to be informed to ask, to your point, to ask those questions. And it's scary. You're like, oh, and we were talking about this earlier. You tend to say, and it's fascinating, we learned this in a couple of our other programs, as a survivor, as a breast cancer patient, you tend to look for likeness. Oh, were you stage 3C, stage 3B, or whatever the case may be? Are you triple negative? Are you ER positive? And you compare, when really there is no comparison, but you're looking for any tangible information to relate to say, oh, I remember I looked at, I'll bring up Aunt Tita. She was such an amazing woman and lived a very long life after being diagnosed, and was such an inspiration for us at the very beginning of Pinked. And I was like, I want to be that. I was looking for anybody that had lived beyond 5 years. I wanted the long years. I want to know, and then I wanted to relate because I wanted to know I was going to be okay and live a long time.
Yeah.
You're looking for that more,
Sure.
I think. At least I was, and looking for that relation. But I did use Google as a tool, and I did go into research articles and try to understand, because you can go down the rabbit hole. But it's not intentionally trying to be a doctor. It's just trying to understand, to advocate for yourselves in most
Absolutely.
and
Right.
it's dangerous. It's a double-edged sword, right? So
I think people, when they get the diagnosis, they feel helpless and they feel lack of control over things. And once you have a diagnosis or a lump, or you are getting this treatment, suddenly people are giving them loads of informations, but they don't have time to process, and they feel they're on a roller coaster ride that there is no stopping, and they feel they need to have some information, and this is one control they have,
Sure.
to have those information. And then I try to tell them not to worry too much, read about it a lot, but at the same time I don't completely discourage them, because I do think bring those information to me, or bring those information to other doctors who are all working in your situation. And I think some good questions have come on that. And once they know that they can ask the doctor the right question, no matter what they read, they can always ask us why we are doing this, why we don't do this. And once they get the explanation, they feel reassured. But if they don't have the explanation, and sometimes if we dismiss them and say that, well, this is totally bad, and then they feel that they are shut down, and they go for alternative sources of information. So I think bring the article to me, we will read it together, we will see what works and what does not. Sometimes they bring a very old article, and I always say, well, this is a new article have shown that this is not. Sometimes there are conflicting articles. One says yes, one says no. So why, and two doctors might have a different philosophy of care. So is the patient's goal aligned with the doctor's goals, and where are we going moving forward? And those are all the conversations it happens.
Yeah.
But then completely believing that, I always say, even the guidelines, they are just guidelines. It's not Bible, it's not completely 100%. Everything is. What you see is not true. You just have to look at it in context.
I agree, and I think, and I'll share a personal experience. My first doctor was not one that I stayed with, because I was made to feel like I couldn't participate. They weren't open to me bringing these articles and questioning them, because I just wanted to understand. It was my body, it was me going through treatment and me living with that, right? So I needed to make choices, and I was advocating for that, but was shut down, quite honestly. And I'm like, this doesn't work for me. I need to have someone that will listen, will help let me participate, and I'm not a doctor, but it's my body that this is being, that I'm going through treatment. I'm the one with cancer, so I want to understand. And for me, it wasn't even control. It was more fear, I think, based, that you look for stuff because you just want to know you're going to be okay, or process it a little bit. And it was a way to process, but I did want to be informed.
Yeah,
and that's hard. And not every physician is open to that. And that's where you have to make that decision of, this doesn't work for me.
Right, and as a palliative care physician, one of the conversations I have with people is talking about this and kind of working through things, but really I ask them up front, how much do you want to know?
Yeah.
Yes.
Because it's not my goal to create a bunch of fear and anxiety about information you don't want to know. But certainly it's not my information to keep from you.
Yeah.
So if it's valuable to you and it helps you make good informed decisions, we're going to have the conversation.
Yeah.
I think there are lots of people who are very analytical, who need data, who like data, and that's great. And there are people who are going to read that information, and there's going to be a wall between that because it's too much. And so I think just trying to put the conversation in the context of who's having it and who's receiving the information is useful. I certainly don't encourage people from doing their own research. You know, I say as a palliative doc, I'll support your decisions as long as I'm comfortable that they're based in knowledge and information, right? Not based in fear and emotion, because it doesn't often get you to where you'd like to be. So,
and I think each patient, what you said is absolutely right. Each patient is very unique and different, and I think there are patients who come to us with saying, you know, what do I do? And they don't want to know more information. They say, what is the right treatment for me? You decide. And there are some patients who will say, okay, give me the information. I need to process. I need to think through this. I need to talk to my family and then come back and say, is this the right thing for me or not?
Right.
And there are some patients who will come with their own information and say, this is what I think you should do. And do you think this is the right approach? So these are patients who come with different ideas, and you just have to see where they are and see how we can work with them in that process. So
I think we're starting to scratch the surface on a topic that is quality of life, right? And how to think about that and define that. And we're going to kind of touch on that a little bit later. So I might shelve that because there's great conversation to have there. Just so we can wrap up the kind of the nuts and bolts of diagnosis and what it means and what are all the terms that people are using. Can you talk a little bit about staging, what it is, what it means as far as local and regional and metastatic, and those types of terms that people are going to hear?
So, you know, they would constantly hear from their oncologist or surgeon about the stage of the cancer. In broad terms, localized breast cancer is cancer confined to the breast. Regional breast cancer is where the cancer has jumped from the breast to the lymph nodes that are drained, you know, from the breast. So usually it's lymph nodes in the axillary region, or what we call as under the arm, or lymph nodes above or below the clavicle, or sometimes lymph nodes in the chest within the same side of the breast, what we call as the internal mammary lymph nodes. So these are all called regional breast cancer. Now, localized breast cancer and regional breast cancer are still curable cancers. It is somewhat easier to cure a localized breast cancer. Regional breast cancer, where the cancer has gone to the lymph nodes, is still curable, but it might need slightly more aggressive treatment sometimes. However, once the cancer has gone outside this, we call it as metastatic breast cancer, or commonly called a stage 4 breast cancer, where the cancer has gone from the breast to the lymph nodes, to other parts of the body, commonly bones, liver, lungs, brain, or lymph nodes outside these areas. And it's important to know this because not only for curing the cancer, the treatment options, but also the survival rates. Those vary between all these stages. So it's important when we see a breast cancer patient, we try to assign the stage and then try to see what types of breast cancer it is and how the survival will impact. And so,
I have a question I want to expand on a little bit. So when someone, let's say, has a local breast cancer and they've gone through treatment, right? Whether that be, you know, chemo, radiation, surgery, or combination thereof, and 3 years later they have another local occurrence.
yes.
Is that still considered a local, like there's some confusion around that and some fear because they're like, oh, my cancer came back, right? So then there's some confusion, and we've seen that with some of our survivors is like, oh, well, it came back. Well, I'd like to understand a little bit more about, did it come back, or is it a brand new cancer, or a little bit of both?
It's a very good question, and this is something that we look at it, what we call as a locally recurrent breast cancer. So we always like to know, is it occurred in the same quadrant of the breast? Is it in a different quadrant of the breast? Was the margins negative initially? Did it come back after many, many years? Could it be a second primary in that area? Or it could be came back very quickly, same biology, is it a locally, the cancer came back. So the prognosis is, it's still curable if we can be very aggressive with those cancers. But definitely how soon it came back. Did it come back within a year? Did it come back after 20 years? So if it comes back very, very late, it can be a second primary. So those are all the questions we try to look at it when the patient's cancer comes back. And we always look at the biology of the cancer. Is it the same cancer? Was it a hormone positive previously? And is it a hormone positive breast cancer? Is it a new different cancer? So
I think people hear the term recurrent, and that means something worse. Yes. And so what I'm hearing you say is there is lots of variables in that equation.
Exactly.
And whether it's recurrence, whether it's a new separate location, all of those factors play into the prognosis and the prognostication.
Exactly. So, and we want to know, did the cancer come back in the same area or in somewhere else?
So is it fair to say you would caution people against jumping to a certain conclusion because they hear the word recurrent?
Yeah, absolutely. They have to clarify. This is very important that they have an ongoing conversation with their oncologist to know, what does this mean? Clarify it. Don't hesitate to ask questions. Clarify this. What does this mean? How will that impact my staging? How will that impact my lifespan? How will that impact my treatment? How will that impact my follow-up? What will happen to my lifestyle? All those questions, they need to have an ongoing conversation with their oncologist once they have their, if they find the cancer in that same breast.
And I think we're going to approach that too in the very next section, because what you're talking about is lots of palliative conversations I'm having with cancer survivors is, these are the questions you need to go ask, right? Not because this is the information that you, as the person who's going to receive the treatment, make the decisions. It's about you. And I think you're bringing up some excellent questions, and I think we'll revisit that because there's some really good questions to try to arm people with, because it's about figuring out what's the right decision for you as an individual, and that looks different for everybody. So
yeah, absolutely.
You had some great questions. I think hopefully we'll circle back to that and add a few more to it, just to help people ask the right questions to get the right information to make a decision that's good for them. So this one's a little hard. I don't really, I'll let you field it, but what's a typical disease trajectory?
Well, I would say of all the cancers, the most difficult question to answer is for breast cancer, because we just couple so many types of cancers in one word, breast cancer. And I feel it's, if you look at the median survival for stage 4 breast cancer or metastatic breast cancer, it has changed quite a bit. And so I have in my own personal experience, a wide variety of survival for patients. And so I always say it's a very personalized. I can give you an average number, a median survival, but I believe this is a little outdated, the median survival, as we speak. The first 5-year survival data for hormone-positive breast cancer patient was just presented in ESMO conference like 2 weeks ago, with thanks to a drug with CDK4/6 inhibitor. Most patients would have known that. And so this is rapidly evolving as we speak. In the 1990s up to 2010, the 5-year survival was somewhere, or the median survival were somewhere only 20 months or something along those lines. But now it has gone up to...
You're talking about metastatic stage 4.
Yeah, metastatic cancer. That's only, it's, but now it has changed for hormone positive breast cancer up to 57 months, and HER2 positive has its own different survival data. So I think it's very, very hard question, and I always think I don't want the audience to take home that when I say an average survival, that is going to be their survival, because it's very individualized. The odds of each person's survival is going to be, I think they have to certainly talk to their oncologist, right? Because someone's cancer came back after 10 years with one spot in the bone will have a completely different 5-year survival than someone's cancer come back within a year after diagnosis. So I want to be very frank about that. Yeah.
And we talk about 5 years survival because that's an accepted benchmark
Yes.
when we're not even cancer, when we're talking about lots of diseases.
Yeah, yeah,
we're using that
yeah,
in the medical world
yeah,
as a data point.
But if you look at the American Cancer Society, they'll say if it's a localized breast cancer, the 5-year survival so for localized breast cancer will be 95%, and if it's a regional, it'll be like around 86%, and then if it is a stage 4, they call it as 28% 5-year survival. But that is a American Cancer Society data, but in my experience, it's very different and very,
So what I am hearing is that there's quite a bit of I don't want to say ambiguity, but there's unknowns, right?
Well,
there's known unknowns, there's unknown unknowns. It's a very individualized diagnosis and prognosis.
Yeah.
And I thought maybe it would be worth, Cynthia, getting your thoughts on that. I mean, receiving information and going through that thought process and doing your own data dive,
We're doing it now, right? So I'll share that. I'll share that, absolutely. So and we've talked about this. It's like every time you get and I say re-diagnosed, but once you're metastatic and you go in and you're like, oh, it's here. And then the next time it's here. And the next time it's here. Every time that's a little bit of a blow, right? Because you're like, oh, it's progressing or whatever. And you have to and we have chosen a path that may not, that's different for us. We have focused on quality of life, and that's been very important for us because I say, and again, we talk about ROI from a business perspective. It's like, it's hard for me to imagine giving up good days for bad if it doesn't yield me very much, and there's no guarantee. So we just try to make decisions that are informed, and we make those decisions without looking back. And so right now we're in the midst of, it has spread, and it's in every bone pretty much, and it loved my bones for a lot of years, but it has now gone to the brain and liver, and unfortunately gone to the brain lining, which is a little more not easily treatable, and the outcome's not very good. So we know that, but there's also treatment decisions that have to be made, and we look at that and say, well, is the liver the tortoise and the brain tumor the hare? Because there's also another brain tumor. And so we're like, which one is going to win? And do I treat the eye if I can live with it? Because I really don't want to treat it. I don't want to go through radiation if I don't have to. I want to have good days, and I'm having good days right now. So we ask those questions, and I will say it's hard for the doctors to give the bad news. It is. I get it. Two of mine were, you just felt their heart sink when they were telling me. They're like, oh, it's in the lining, and it was defeat, right? But my challenge was, I need to have as much information and as much data that we can have. So yes, I've done MRIs, yes, we've looked for the leptomeningeal spread, we've done all of that, but there's still no answer for how diseased am I, because we didn't go the route of scans every 6 months. We just didn't do that. We chose to treat me instead of the scans. And so that's been a challenge, and we're in the midst of trying to get more data. And the question we asked is like, well, you can't answer that for me. He can't answer. He's like, well, I don't know. I don't know. It could crop up. So you have to ask questions of, if I radiate this tumor, what am I going to pay? Nothing is for free. I know I will pay a cost. Nothing's for free in this world, in anything really. And so if we do that, what's the goal of the treatment, right? You're not going to cure me. That was off the table a long time ago. So our process has been, what is the goal of the treatment? And they can answer that. And the answer is X, or it's like quality of life to shrink the tumor. And then the next question is, well, if I don't do it, what might happen? Mm-hmm. And it's, okay, well, it's going to grow. There's no doubt it will probably grow and impact muscles and nerves, and it's around the eye. So then the question is, but what if I still don't want to treat? You're shrinking it now, but in 3 weeks or a month or 2 months, if it starts bothering me more with pressure, and I come to you and say I want to do something to relieve that pressure, the question was, is it preventative in any way, or do I have to do it right now? And the question is if it gets damaged, you're going to live most likely with the damage that it's already done. I can't reverse damage, but I can shrink it to alleviate further. So that's a treatment decision that we have to look at and say, oh, roulette wheel, right? Like red or black. And are we betting that it's going to get worse? Or are we betting that the liver is going to get worse faster? And so we all agreed that we needed more data points. And so the data point that we need now is a full PET scan so that we can get a better, something that's more analytical and more, get a better prognosis of how diseased everywhere else is that we haven't done in a few years, right? So those are the decisions where I find that it can be frustrating as a patient when no one wants to give you they're giving you the bad news, but they're like, well, it depends. It depends. And it does depend. But I need data. I need to get to a point that I can feel good that I have as much information as possible to make the decision so that I don't look back, that I just go live. I just make the decision, do it, and go live my life as long as I can. And we're not there yet. So it's been a frustrating probably 4 or 6 weeks, something like that, because no one wants to go, they don't know, and I get that, and I'm not asking for a crystal ball, but at least I feel like as a metastatic patient, I'm like, I'm not asking for a crystal ball, but I am asking for you to participate and give me information so that I can make the decision that I need to make, because I don't want you making it. You're not living in my body. But that's been our challenge over the past couple of months, quite honestly. So,
and I think that last 3 minutes, that takeaway, if people can think in that mindset, that takeaway is really, really important, right? Whether you're local, whether you're regional, whether you're metastatic, it's all right. Like you said, there's nothing for free. You know that radiation to a part that's having trouble comes with side effects.
Absolutely.
They're known side effects, right? What you don't know is if you don't do treatment,
right?
Do you ever get, it's a very, very, do you ever get symptoms that are going to cause you trouble?
Right.
And if you do and you didn't radiate, you're going to wish you had.
Right.
If you don't and you do,
right.
That's what when I talk about there's some ambiguity or unknowns, the data is known, but how is Cynthia going to behave
exactly.
Versus anybody else? That's the hard piece to say, we don't know.
Right.
And so we're asking you to make potentially life-changing, certainly quality of life-changing decisions without hard answers. And that's a really, really difficult thing to work through.
So yeah, I completely agree. This is one of the reasons why it's very personalized for each patient, and the goal of each patient is very different. There are patients like earlier we talked about how a 30% response or 40% response, the same number, two people will look at it in two different ways. One of them will say, it's only 30% response, it's not worth it for me. They'll say, the other one will say, wow, it's 30%, I'm going to take that one. So that's what I realized is the patient, and also I think the patient's perspective of life, it brings a new dimension here. What's their philosophy of life? Where are they in their life? Do they have young children to raise? What goals do they have? At what point they think it's not, they don't want to keep coming to doctor's office anymore. How many scans they want to do? Where is their disease, cancer, metastatic disease? Is it only in one bone, or is it like in the vital organs? Is it impacting them? Or they have metastatic disease, but they are living their life with the disease. It's not affecting their life, and they don't want, whereas the treatment might impact their life. So these are all so many variables, like you said, and it's best that each patient makes that decision with their oncologist, who's aligned with their thoughts. And so, as physicians, we are able to provide the data. We are able to some extent analyze their cancer and able to say what are the likelihood of them responding or doing things. The toxicity, to some extent, we can predict, but it's still an unknown thing. If you say 20% chance of you having diarrhea, are you going to be that in the 20%? Are you going to be the 80%? So that is the the odds of you not having side effects is, we'll say the odds of this having a lung inflammation is going to be only 5%, but if you are in that 5%, it's 100% for you. So that is the situation where, as physicians, sometimes we struggle. We can give you a percentage, but if you are in that percentage, it's 100% for you.
Right, and there's the known unknown, right?
Yes.
And I think in that situation, it's if there's somebody who's gone through treatment, and now the question is, should you pursue more treatment? Personal history, even though the agents might be different, you have plenty of people who went through it and are like, I'm not doing that again. And you have other people who really, from a side effect profile, from a quality, tolerated it very well, and they say, I'll do that all day long. So it really is quite personalized and independent. It's based on cell type, and that leads to, there's a question from Laura asking to explain the difference between HR positive and ER2 cancers and
hormone negative cancers is the one.
And why can you have both?
So breast cancer is a very heterogeneous disease. What that means is, again, I said, like multiple cancers are put in multiple cells. You can have a few percentage of cells who can be which can be hormone positive, and there could be another tumor in the same breast which could be hormone negative. Is that I think that's a question she asked, and I think yes, Laura, you can have 2 or 3 tumors in the breast, and that's why when we see 1 at 2 o'clock position, 1 at 6 o'clock position, we try to analyze both the tumors to see whether each one of them, are they hormone positive, HER2 positive, and we'll also, just because we checked one tumor does not mean we don't check the other ones. We try to check the other ones as well, yes. And they're a group of diseases, what we call as heterogeneous clones.
So Tiffany, Dr. Geetha wants to see if there are any websites that you suggest that are reliable sources.
Yeah, I would say ASCO, American Society of Clinical Oncology, and then American Cancer Society has got a lot of information. And those are the 2 places where I would say.
ASCO is at asco.org.
Yeah, and then American Cancer Society has a lot of information on that too. So those are the 2 places where I would go. And then your doctors will have their own informations providing to you based on medications and the treatment. Yeah.
How about Wikipedia? Is Wikipedia a valid source?
I do not.
I throw that out there because it's a common. I mean, there is lots of good information on Wikipedia. There's lots of bad information. It's not a place that I would recommend anybody ever get medical information because of the nature of the open source. And, so I just throw that out there because it's a website that I hear a lot when people ask me that question. So do we have any other questions? Okay. So I think that's excellent. I think anything else you want to add to the kind of the diagnosis, terminology?
Not terminology wise. I mean, I think we speak a different, like we just found out, like a business speak versus a medical speak. And so I think that's fun, right? I learned, and so that's kind of interesting. But yeah, I don't think so. I think this is a great topic. So good conversation, I think, at least.
So I think the next study we'll just kind of launch into a little bit about treatment, probably quite a bit about quality of life and how those 2 interplay and what that means. And we'll kind of run through that and see where that takes us. And then that's probably, my assumption, is where we might have some more questions. Because it gets very individualized at that point. And so, one of the questions people ask me, which is really an oncology question, but what are my options, right? And I know that's a huge umbrella under which there's lots of answers.
Yeah. But so when and I'm thinking this is with relation to metastatic breast cancer, so I'm going to concentrate on that if that's what we're because the treatment for earlier stage cancer patients and treatment for metastatic cancer patients, even though the medications are somewhat similar, the goals are different.
Let me back you up a little bit, and you add to this too as you want. But let's before we launch into metastatic, what about treatments for localized cancer?
So when a patient comes to me, They come to me in like either as a localized breast cancer or a regional breast cancer or metastatic breast cancer. So if a localized breast cancer patient comes to me, they usually have a surgeon and a radiation oncologist. So the treatment at that point is, the goal is for sure cure. So local and regional breast cancer, the goal is cure. So the treatments are somewhat intense, but that is relevant to that particular patient. Not all patients with localized and regional breast cancer need chemotherapy. There are so many tools thanks to what we call as a genomic assays, where we analyze that individual patient's cancer cell to see whether they need chemotherapy or not. Now, before 2004, I would say we have been giving chemotherapy for anybody whose cancer is more than 1 centimeter in size. And we were blindly making decisions based on the size of the cancer. However, there are a lot of genomic assays, and your doctor might do a test called as Oncotype or MammaPrint or different assays. And that particular patient's tumor is sent for that specific test. So it's a very personalized test to see what are the odds of this cancer coming back, and will chemotherapy help. And so we use that a lot for hormone positive breast cancer patients. However, that does not apply to a type of cancer called as triple negative cancer, which is one of your aggressive cancer, or HER2 positive cancers. But certain cancers we like to, as patients like to avoid chemotherapy, we like to avoid chemotherapy too. And so we would do those assays for those patients to avoid treatment, and that is a very set defined treatment for those patients. There's not a lot of variations in those patients.
Fairly protocol driven.
Fairly protocol driven. There might be little nuances in type of the chemotherapy, or do you want to add a taxane or no taxane, what are the risk benefits. So there's a little bit of nuances, but there's a little bit of style of working based on the oncologist experience and all those things. But for the most part, these are very standard driven treatment options for earlier stage breast cancer patients. However, it's very different for metastatic breast cancer patients. The patients in metastatic breast cancer patients play a very major role also in their choices of treatment, because at that time, the goal is no longer going to be a cure of the cancer. There, the goal becomes, can we prolong the life? Can we prevent the symptoms from the cancer? Can we minimize the toxicities and symptoms from the treatment? So how do you balance that? So that's where the art of medicine comes, and the goal of the patient's desire and everything comes into play in those situations. So there is a lot of nuance in that, how you treat a metastatic breast cancer patient. Whereas in earlier stages breast cancer patient, it's very, because the goal is cure, it's very structured.
And I think with more advanced disease, with metastatic disease, certainly there are some other players in the medical world, in the non-medical world, that you and I have talked about, that I think that should be included in your team.
Yeah.
And we're going to talk a little bit
Sure.
about that towards the end of what does your team look like and who could it include.
Yeah.
But I think we're starting to talk about treatment. We're starting to talk about early on, like you said, fairly protocol driven. Mm-hmm. We know what we're after. You get the cell type, you get the genetic studies, and your treatment is fairly specific. Yeah. Certainly more specific than we were 10 years ago.
Absolutely.
Right? That didn't exist.
And that's
at
very
least to
unique
that
for
degree.
that particular patient.
Mm-hmm. As disease progresses or is progressed at diagnosis, now the discussion of, and now, just to back up, that treatment protocol, my assumption is most people would pursue, given
Yes.
the presentation that it's intense, but it's curable and the intensity is a fairly short.
I think, and there also to some extent the patient drives the decisions. We give them the options, we tell them what it is, and we tell them the odds of cancer coming back with chemo, without chemo. And again, that number is very interesting, how each patient perceives that number. And we certainly include clinical trials in earlier stage as well as in metastatic. So that will be also another option that we look into it. And the patient's age plays a role.
Sure.
The patient's preference plays a role, even in curable situation. Yep. The patient's other health conditions play a role, even in that situation. So it's still a joint decision making. But the treatment for that cancer is pretty set, but then how do you apply it to that particular patient? If they have a heart problem, can I give a medicine that is affecting their heart? So there you take if they are diabetic and they have terrible neuropathy, what do I do with that? This is the right treatment for that cancer, but they cannot handle, their heart function cannot handle. So what do I do? How do I tweak it? So still there is some variations, but kind of fairly set, yeah.
Yep. Is it common to get thyroid cancer after breast cancer? And is that considered metastasized?
That's a good question. I think what we need to do is the thyroid biopsy. Is it a thyroid cancer that started as a thyroid cancer? So when we do a biopsy of the thyroid, we will know the type of cancer. And usually if it's a thyroid cancer that started in the thyroid, it is not metastatic breast cancer. Now, sometimes patients can carry a gene that puts them at high risk of other cancers. For example, BRCA2 patients are at risk of developing thyroid cancers, or patients who have Li-Fraumeni or other syndromes that puts them at a higher risk of developing other cancers. So in that patient, I would always find out whether they carry a gene that puts them at risk for multiple cancers, number one. Number two, if the patient has received radiation for the breast cancer, especially to cover the lymph nodes above the collarbone, what we call as a supraclavicular lymph node, in those patients, if they had radiation, a delayed radiation side effect, patient can develop thyroid cancer. So I would like to look at those aspects if the patient has thyroid cancer and breast cancer.
It's possible to have two distinct, separate cancer diagnoses that are not related. One did not come from the other.
Exactly. Yeah. Mm-hmm.
But what it does start to bring up is the discussion Cynthia was starting to have is quality of life, right? And that's really, really important. I mean, ultimately, we want people to live as long as possible, but as well as possible. Right. And sometimes that trade-off exists. And the questions that you're asking your docs and yourself are the questions I think that help people work through that process. And so one of those things is to sit and think and talk about with your family and your support team, what are your goals, right? What's important to you? And what it always kind of circles back to, whether people put the term to it or not, is quality of life.
Yes.
And that's defined very, very differently for everybody. I've had patients that say, if I can open my eyes and see my grandkids, that's acceptable to me, and I'll go through whatever it takes to get to that point, because that's valuable to me. And you have other patients on the other end of the spectrum that say, if I can't dress myself, if I can't go to the bathroom independently, if I can't do X, Y, or Z, anything short of that is not worth further treatment burden, right? And so that's a really, really wide divide, and that's what I hope that we can start to stimulate the conversation, is to think about those things. And as we're kind of learning from Dr. Geetha, there's lots of unknowns. But there are some knowns, and there is data, and there are questions to be asked that lead us towards a decision that's right for us. And that's really, Cynthia, what and I appreciate you sharing your experience and your story, but that's really what you're talking about.
Absolutely. Right. It is the reason actually Project Pink even exists, right? And I wasn't even metastatic at that time. But I think what was, if I could, a nugget for us, at least from the beginning of the metastatic, and it was even at the beginning of the original diagnosis, but we'll focus on the metastatic diagnosis, right? The first time, and I didn't even know this, but I can't pronounce it. I was only in one place at the time I was diagnosed metastatic. And, it was like, I knew at that point it wasn't curable. It would never be curable. And it was like out of the barn, right? What we would say in Texas. And so, I was fortunate, at least, that my oncologist acknowledged that it wasn't curable and said, what are your goals personally? And we had to ask that of ourselves. but it was a conversation my husband and I had to have. We kind of knew we are very strong in our faith, and we are at peace with what, but we believe we have a responsibility to listen, be informed, and make decisions, because we live with the consequences and nobody else does. So, everyone's in our life is impacted, but that was our approach in, let's understand what's important to us. To your point, is it burden becomes a really big deal for me. I don't know of many people that want to be a burden, but quality of life, to your point, is defined very differently for everyone. And my doctor asked me, what is important to you? What is your goal? And how do you define that? And I had not just her, but it was interesting as I moved through my care team, because people get added to your care team, and one of those was a amazing pain management doctor, and she's like, but why aren't you doing this and this and this and this? And my oncologist was like, have you talked with her? Because she's not going to give up. Like, she had a horrible first round of disease, like with treatment, but we were very set in this is what we are willing to do, and we're made that decision, moving on. We'll listen, but our goal is this. We want to get up, but I want my feet to hit the floor if at all possible. Yeah. And I want to be a participant in my marriage, in my family, in Project Pinkton, our community. And I will do that as long as I can, but I don't want to say I'm going to go be sick for 6 months just to get 2 months, right? So that was our approach. And
that's an excellent point. And that's a lot of when I'm talking to palliative patients about, here's some questions that you should ask your oncologist, because it's information you need. Right? When something's being offered as far as a disease-focused treatment, what is that? What is, in best case scenario, what's the outcome we're expecting? And how's it going to make me feel? And if I chose not to do that, what does the outcome look like? And I think those 4 questions start to really help people figure out if that particular intervention is the right thing or not the right thing for them. And you were telling a story of the other doc, and it said, why wouldn't you go do this? Why, there's these things available. And my point, my counterpoint to that is maybe. But simply because those things exist does not mean that they should be utilized in everybody, right?
And at least with, it's hard to say no. I mean, like, some people don't realize it's like, in the world, we are meant to thrive, right? Survive or thrive, and you want that because it's survival, right? Like, we're wired for that. But to consciously say no to something is as hard as saying yes, in my opinion. And for me, it's harder to say no sometimes than to say yes, because then you're like, am I quitting? Right? Like the psycho part of that, psychological part, it's like, but I'm not quitting. I'm making a choice to live my life the way I need to live it that works for me. And that the first time we said no, it was hard, and we had to really give it a lot of thought. Because you have doctors that are wanting you to get that extra month. But it's not that month isn't precious, but not at the cost that it would cost us based on my personal history. And that's a really hard, no is harder than I thought it would be. So I think that's the scary part, at least, that we had to work through in full disclosure. It's like, oh, no. And you have to work through that. And that was hard, I will say, but it works for us. And I would, to your point, ask the questions, because I can remember when we were, and still now, it's like, okay, take the data, but do we ever ask, what does that buy me, right? When you're choosing a treatment, understand that it's 2%. Understand that it's 2% and only statistically going to give you an average of 3 months. Let's be, face it, and that's what was scary for us. It's like, those are hard questions to ask, because are you ready to hear them? Because if you're not ready to hear them, it's really scary, right? So, and it's scary regardless. But for me, I had to ask them, and I had to step up and just say, but we need to know this, because it's a price we need to decide whether we pay or not.
Right, and I think the extreme example is if say Dr. Geetha has a treatment to offer, and somebody says, well, what does life look like if I pursue that treatment? And the answer is, well, potentially another 6 months of life, but you're going to feel horrible for 4 of those months, right? And then the question is, if I don't pursue treatment, you might have 3 months, but you can pursue a palliative, a comfort-focused plan, and feel as good as you can, right? And so, and that's an individual like I said, it depends on who you are and what's important to you. And I would say also very much depends on the time of life that you're in, right?
Exactly.
I mean, my kids are in junior high and high school, and if I had an advanced disease, I would be aggressive, and it wouldn't be for me. It would be because for them. Does that look different in 5 years when they're in college, or 15 years when? Certainly, it probably does. So I don't mean to complicate the discussion, but we're talking about really scary, hard things. But if you don't have the conversation, you and I have talked about this, right? And the line that I really, really don't like to see people cross is where you are being done to rather than being done for.
And you
right?
know that point. I will sit here and tell you right now, you know in your heart and in your gut and your bones, literally and you know, it's like, okay, really, I feel like I'm done too. I'm tired of, like, you're just like, really, another scan or another this or another that. And it's just like, really, I just want to go and be with my family and play with my dog, and so you get, it's a gut feeling. I hate to say that, there's no science around that. It's just whether or not you're ready to face that and face it together with your family or your loved one, because they're walking this with you. One of the things that's been important for us is it's not just me going through this.
Absolutely.
There are people that are in my life that are walking this journey with me, and I get there as much grief. It's harder, in my opinion, for them than it is for me, because I get some, in my world, it's my choice, right? But I make it with my spouse. But, they're going through it in a different way. And and you have to consider that.
And in the palliative world, as a palliative provider, as a hospice provider, I'm getting those people, and we oftentimes don't see where that line is until we've passed it.
Yep.
And then we look back and,
I wish I would have,
Right. But I think I have seen over and over and over, when we don't have real, brave, hard conversations, that line gets crossed a lot faster and a lot more than I think most people would probably choose. So
I agree, and I think, and we'll get to it later on in a different topic, I'm sure, but it applies here. And I would encourage anyone to try to look at it this way. I hope that by us asking those hard questions, just like you have to ask those hard questions to plan for end of life, if you ask those hard questions, I hope it's a gift to your care team and to your family, right?
Absolutely.
So that it makes that, because they know my wishes. They know what's important to me. And so I hope that's a gift to them to make their job easier, because I know that y'all do an amazing job as physicians. I mean, and you go into it with a heart. I mean, and it's a hard job, but I hope it makes it easier for you, so that the whole team that your wishes are honored, that line isn't crossed if they know, and you've done those hard questions and you face those fears and you just have those hard conversations.
Absolutely.
Yeah.
So Tanya wants to ask that she's thought about asking what happens if she doesn't pursue treatment, but I thought the doc answer would always be not sure. Do you agree with that?
No, because I think if they have metastatic breast cancer, or if that's a context we are talking about, your doctor will be able to some extent, tell you the trajectory of how the disease will progress depending on the location of the cancer, or how you will feel, what's the age of the patient, and what's the life expectancy will be. And so a lot of the times they might be able to give you a rough idea of what will happen if you don't choose treatment. And you made a very great point about patients asking questions about this. And I think when I see patients in my office, I think patients come in different perspectives. I think you seem to be a person who's very clear in what you want and what you do not want. Yep. So when a patient comes with that kind of conviction, they clearly know where they are in their life, what they want and what they don't want. It is somewhat easier for the doctor to kind of take directions from the patient and kind of guide them. There are some patients where they are not sure what they want, and they are in a tougher phase in their life. They they have young children to raise, they want to be aggressive with their cancer, they want to take care of themselves, but at the same time they do not want the complications of the treatment. And so there's a nuance here, that's a tougher decision where they want to live life to their fullest, but without the wanting to, the side effects of the treatment plays a negative impact. And sometimes it's just young patients struggle with a diagnosis, or especially if they come with a stage 4 at the get-go, they don't have any experience with oncology. Here they are thrown into our world with no prior experience, and now they are dealing with all bad news. And it is a harder process. So that journey is very difficult for those patients. So I think as doctors, allowing them space and time and kind of having small, short but multiple conversations over a period of time, giving them enough information, let them go back home, process that information with their family members, come back 1 week later, ask more questions. And so before making any choice and decision, sometimes in treatment. So sometimes I have to do that in small, frequent sessions, just because if I give a lot of information in one day, it's not going to, after 15 minutes, it's not going to go through it.
And I think in line with the question that was just asked, I'm going to ask a question that I've heard lots of people say that maybe you probably don't hear it, because when people are considering not pursuing treatment or not continuing, I've had lots of patients who say, I was scared to tell my oncologist that. I didn't want them to judge me or be mad at me. I know that's not happening.
No.
But that perception, can you just speak to that piece a little bit?
Yeah, that's a very good question. So, and it happens in kind of two different ways. One, the patient does not want to, displease the doctor. They don't want to be judged as a quitter, I quit the treatment. They also not want to, they also don't want to upset their family members. And so sometimes they go through the motion of going through treatments without actually having a sense of purpose of what they want to do. So, every now and then we try to kind of stop and ask, what do you think? Why are you, I just had a conversation with you last week about a patient of mine who is responding to the treatment, doing okay, no major hospitalization or sepsis, but just tired of doing things and being in my office, just tired. So you just, in that sense, you can sense the tiredness, and then we have to say, okay, what's going on? Let's kind of just chat. Today, no treatment, just let's talk. What is going on? And, then that helps us to open the conversations. But you have to have a sense of what's going on with your patient. And there are a lot of nonverbal cues, more than the fine can have so many meanings. When my patient tells me, how are you doing? I'm fine. But you can say, you're not fine. What's going on? And then they'll say, yes, this has been happening in my life, or this is what is going on, or what's going on. So you have to kind of, a lot of the times, the nonverbal cues is what I'm able to pick those senses, and then we have to kind of, address it. And then they tell me, okay, gosh, like I told you, that patient was like, I'm afraid of palliative care. I think that doesn't mean I'm going to go on hospice right away. I'm going to die the next day. No, it is not. We are kind of managing the symptoms. Will my family be upset with me because I'm stopping treatment? And no, it's not going to. It's your choice. We have to talk, and we have to make sure that they are accepting. So these are tougher conversations.
Should people have a fear of expressing their true wishes to you for concern of judgment or getting mad at them or any of that?
Yeah, absolutely not. I think I always say we're all on one side, cancer is on the other side. That's how I look at it, because I feel like the patient, everybody works for the patient, and whether it is palliative care or oncologist, and this is just one tool. Chemotherapy is not everything. It's just a tool to help the patient, if possible. Everything is, we have all these tools, does not mean we have to use all the tools. And so at the end of the day, I don't want the patient to think that they are failing us, or that they have to do it for their family's sake. I think what feels right for them is what they have to do. Of course, if it's a curable cancer, and I feel like it's a Hodgkin's lymphoma is a curable cancer, and they choose not to do, I probably will try to beg them to consider a second opinion. I will try to make sure they go and are curable, so it's a different goal.
And again, that's really presenting information, right?
Yeah, presenting
I mean,
information.
if somebody says, no, I'm not going to do that, and you say, well, it's 99% cure.
And then
it's horrible for 2 weeks,
but you will bounce through it. I'm confident that you can get through this.
And I think our ethics and morals as providers we would push that conversation a little bit.
Oh yeah.
When it becomes less clear, when it becomes much more individualized, there's no judgment, right?
In a curable setting, or even in a palliative setting, if I feel the response is going to be good and they're going to have a good days, and I feel that they can clearly tolerate treatment, we would recommend doing that. And I would not, of course, we would ask them if they have a different opinion. We would say, why don't you go see a different opinion, see what you think, because I am a little bit confident here that you will respond to the treatment, and you will do well, and I have a feeling you will tolerate this better. And so those are all ongoing conversations, but we always make it clear to them that they don't have to please us, because at the end of the day, it's their life, and we want them to do well.
I say this is about you and your family unit and your support unit, and what's right for you might be different than this person sitting next to you. And it really, what this conversation is about, and this series is about, is helping people have the conversations to think through those, right? And to have a plan A, but maybe also plan B and plan C, so that when things happen and go the way that you didn't think they would, that we're able to shift and into plan B without hopping from crisis to crisis. And so hopefully this conversation is helping break some of that down a little bit.
The other thing I wanted to mention here is sometimes we give treatment holidays a lot, because metastatic disease is an ongoing process, and these patients have to go through, there is no set goal. You do 12 treatments and you're done with the treatment. This is an ongoing process, and there is a fatigue of going through this motion of scans after this and this. So we just say, time out, just go take a break, do what you have to do to rejuvenate. And then when you feel it's ready to have this conversation again, come back and we'll talk. And so we do give treatment holidays. We think about it. We try not to do scans before vacations or holidays, and definitely there are a lot of art of medicine is there.
So there's a question that says, who is actually on your team of healthcare providers? And actually that's the next big heading in my outline, talking about your team, right? And there's the medical team, and this is maybe a great question for you to field. That medical team, obviously an oncologist, typically a radiation oncologist, often a surgical oncologist, a reconstructive surgeon, right? I would encourage palliative care provider, absolutely. Certainly you might have your primary care physician remain involved. You might have a nurse navigator from the oncology clinic or whoever's helping you navigate all of this healthcare stuff. You might have a pharmacist. You might have a lymphedema clinic.
Nutrition, dietitian.
Yep, dietitian, physical therapy.
Psychologist,
social worker, and you might have hospice.
Genetic counselor,
Right. So that's a big team. I would say I don't see lots of people that have all of those members of the team, but those are all valid members at some point in somebody's disease progression that they all serve a purpose.
Yeah, I would even say that a couple that to add would be even occupational therapy in some situations, and then pain management has been critical for me living with my disease.
Right, and we can talk about pain management. We can, if you're talking medical pain management, I think that's palliative care specialty. If interventional, meaning needle procedures, essentially, right? Epidurals or nerve blocks or ablations. That is an interventional pain doctor, a great tool to have on your team as well.
Because they're able, I mean, I tease and say I glow. I've been radiated so much. I glow in the dark, right? Because it's been effective for my bone mets. But I tell you, when it didn't work the last 2 times, but seeing pain management and then doing ablation on most of my lumbar, boom, it helped tremendously. And so that improved my quality of life so much when nothing else was working, because I really have an issue personally, not because I'm scared of them, but they make me really sick, and pain meds I struggle with medication. And so I don't want to be looped up all the time. I don't like how they make me feel, and I hate nausea. So it's like, that is not a good quality of life for me. So I had to pursue, I was like, I can't do this. I want something better. And I just kept advocating, and it was great. So
sometimes it's a great tool. It's one and done.
Yep.
Maybe it's repeated in 3 months or 6 months.
Or 9.
And sometimes it doesn't work. But absolutely a valuable provider in your toolbox of your team. So we have another question that says, how do I approach my doc when I want to get another opinion?
I think just talking to the doctor is the most important thing. You just can, I think having an open conversation with the doctor, and the doctor will help them arrange for a second opinion. The patients can also choose on their own, but I think they should be having that comfortable conversation with their doctor to say, hey, I would like to seek a different opinion, and it's certainly in their prerogative to do that. And a lot of the times the doctor themselves will be suggesting either locally or to go to other centers, depending on what specialty of breast cancer it is. And some centers are known for certain types of breast cancers than other centers. So definitely having a conversation. I think most oncologists would not be offended or upset about that.
Is not an offensive question.
Yeah, it is not at all an offensive question. It opens up more conversations, and the oncologists only serve as a tool to help the patient. So
I would say as a palliative provider, I actually encourage people for second opinions. I think anytime something's going to be done that's not reversible, you probably should have a second opinion. Not because I don't trust the first opinion or the second opinion or the seventh opinion, but because I have more confidence that you're going to make a decision, right? If you go see 4 providers, you get 4 opinions, and they're all in agreement, you're going to have confidence moving forward that your decision is the right one.
Exactly.
And the more confident I am that people have that information, the more I can support them in their journey. So if I don't have all those members on my team, who actually takes the lead?
So typically, the medical oncologist usually takes the lead. Sometimes in the initial phases, the surgeon takes the lead, even in earlier stage cancers. However, in a metastatic setting where the cancer is stage 4, I would say the medical oncologist takes the lead, because the patient sees them the most often. So I feel like the medical oncologist should take the lead in terms of when to refer them to radiation, when to do the scans. As a medical oncologist, you will know the patient really well. You clearly know what's going on in their lives. You clearly know pretty much how many kids they have, what job they do, what their goals, what their personality, what they're looking forward, and what their desires are. And so a lot of the times you are able to say, okay, this patient had only 1 node removed. They don't have to see a lymphedema specialist. This patient had multiple nodes removed. I'm anticipating lymphedema to be a problem. I will put the referral before they develop a lymphedema. And so if you're anticipating the liver disease to get worse and where I want to do ablation, then before you contact the interventional radiologist to make that arrangement. So most of the times, or if they're losing weight, or if you see them depressed, do they need to talk to other person? And sometimes we refer them to other providers, because the patients tend to put a brighter face to oncologists. For one of the things is also they're afraid to tell us that they're not happy, or they're sad. They're afraid that we would stop treatment. They're afraid sometimes that we will tell them no further treatment. So they have all those pent up feelings, and they're not able to openly communicate sometimes. And you can sense that, and you can send them to different providers who are able to explore, okay, is this patient depressed? Do they not want treatment? What are they thinking? And sometimes those tools help, but typically medical oncologist. And I'm hoping most patients have a good relationship with their oncologist.
I would piggyback onto that to say the best gatekeeper is the person who's going through it, right? That's a hard role to play when you're going through what you're going through. But sometimes those pieces are obvious that we need to involve, and sometimes they're not. If you don't advocate for yourself, those things might not be known. Do you need a chaplain support? Do you need a home health aide? What is it that you need? And I think you have to be comfortable to bring those things up in some way, right? And I think I would tell you, like, there's things that Dr. Geetha does, and there's things that I, as a palliative care doc, do, and we work really well together. She can then focus on the chemo and the disease-focused treatment and the markers and the genetics and all that comes with that. And I can focus on treating pain and nausea, and it's not one taking over for the other. It's very much a collaborative, interdisciplinary approach, which is the best approach, I think.
Absolutely. And I think having an ongoing conversation between the two doctors to help the patient. I also think patients are more open sometimes with the palliative care team about their fear or their anxiety or stress, where with us they are more concentrating on imaging and other things. In a good relationship where they have a long relationship with their oncologist, they're able to blend back and forth easily with their oncologist. So, but it does help us out in terms of symptom management if there is another provider to help us out, so that we can focus on the disease part.
And we would never expect people to know who those team members are or what their role is or even what their name is. I just encourage people, if you have a need, you just need to voice it. You don't have to tell me what the solution is, just let me know what the problem is. And either I'll work through it, I'll call Dr. Geetha, we'll call physical therapy, whatever. But we can only really work with the information that's given, and being comfortable to have those conversations with your providers, I think, is really, really important.
Yeah, and in the initial visit with the oncologist, most of the times we kind of go through a lot of symptoms and try to see what kind of symptoms is the most pressing problem for them, and try to kind of make those other providers. One of the fatiguing part for the patient is also going through multiple doctor visits, and that is one thing I feel like can be as such exhausting. So when I try to refer a patient to a palliative care provider or other things, sometimes patients are, do I have to really one more appointment, one more day to get up and miss my work or miss my time with my kids? So we have to kind of balance it out as well. And sometimes we try to couple a few appointments back to back on that day, so same day, but that day becomes a very exhausting day. So you have to kind of balance it out in that sense. Yeah.
There was a question that's, what's the difference between palliative care and hospice? Excellent question, very often misunderstood. I think we have a topic that's, another talk that's really digs into that a little more. I don't want to brush past that, but I think we'll save the bulk of that conversation for one of the upcoming talks. I think very briefly, palliative care, the focus of palliative care is quality of life. It's symptom management, whether that's pain or nausea or shortness of breath or fatigue or loss of appetite. It's symptom-focused, patient-focused, quality of life-driven care, right? Palliative care is just another medical specialty. It's like involving cardiology. When you have a heart problem, get cardiology involved. When you have a quality of life or a symptom problem that's accompanied by a severe or life-limiting disease, palliative care is absolutely the right thing to involve in your team. Palliative care can be provided and delivered alongside aggressive, disease-focused, curative-focused measures. There is nobody goes on to palliative care, so to speak. That's the term I hear a lot. You can involve palliative care, and if your situation is curative and you do great and there's no need, then palliative care will slowly back out when the job is done, so to speak. If that is a disease progression, palliative care will get more involved. And eventually, the end of that spectrum is hospice. And hospice is palliative care, but a very defined, specific entity, so to speak, right? Hospice is a team of individuals, and we'll get into that later. Hospice typically cannot be provided at the same time as curative, aggressive, disease-focused treatment. That's the real big distinction, I think, that's worth mentioning tonight. And I think in a couple talks we'll dig into that in a lot more detail.
Yeah, and I think one of the confusion for the public is that they equate palliative care to hospice. So when we try to refer patients for palliative care, they assume that means the doctor will not give treatment for the cancer, and they are so afraid of the palliative care and start tearing up sometimes even. So I always say, no, this is another doctor to help you with the symptoms of cancer and symptoms of other things to explore. That does not mean your treatment is not going to be stopped, and that is not equivalent to hospice. And there are studies have shown that there is increased survival when they are done hand in hand. The only, at least in Omaha, we have a shortage of palliative care clinics as an outpatient. So one of the challenges for oncologists is, we are trying to recruit palliative care physicians in our clinics and to have scheduled clinics with us. And we do have some services available with Nebraska Cancer Specialists, but still it's so hard to get an outpatient appointment. And so as oncologists, we wear both the hats till we find an outpatient clinic where we manage the symptoms as well as be the treatment. And so I think it'll be nice to have a lot of palliative care clinics available for those patients, so both can be done hand in hand.
It makes a huge difference. Speaking from a patient perspective, palliative care has so much, it just makes a huge difference in your quality of life.
Absolutely.
Because they have so many things in their toolbox that it allows you to do your thing. You're exactly right, but they do their thing really well, and having them on your team is amazing and makes a huge difference. I wish they were more readily available.
And I think the tools that, like you said, that palliative care uses are sometimes not typical.
No,
right?
they're
It's typical in the
not.
palliative world.
But it's not in the regular world.
But we use liquid meds in high concentrations. You can use creams and patches, and you can use little tiny needles that go under the skin that are not IVs, that don't hurt. There's lots of options. And I would say lots of what I do in palliative care is symptom management. The bulk of what I do is conversation, right? The symptom management part, that's great. That's pharmacology. That's the science behind it. The role of palliative care is to unpack all of the medical stuff and really help people work through that and have this conversation so that we can assure people are pursuing a path that's right for them.
Right, and I think and to your point, and you're right, there is a lot with the pharmacology, but there's also, when you involve palliative care, there is so many other tools that are available, whether it's massage or acupuncture or acupressure or whatever that is. There's additional tools that are outside of the norm sometimes that, and I don't want to say norm, that's probably a bad word, or not bad, but just
they're not mainstream.
They're not mainstream.
Right.
And some are very effective for some and not others, but it just opens up more tools, and and I don't know if it's because they see it and they're focused just on that, so they're able to have more and not focused on the stuff the general oncologists. But it's just they're amazing to have on the team. So
Absolutely.
Palliative care is more
difference.
prominent than it was 5 years ago or 10 years ago, but not nearly where it needs to be from a community standpoint. So, right, as you're pointing out, and as you're probably seeing.
Right. I wish the minute you had to go for whether it's oncology or some other long-term illness or some battle that you're battling with, I wish it was just a standard part of your team management, right?
Yep.
Just so unfortunate that we just have such a shortage and it's not there yet.
Yeah.
Yep.
Right.
And then there is a shortage, and it's not Omaha specific. It's the system in general. But I think down the road that looks different. It's changing every year.
Yeah.
And that's a good thing. So are there any other questions that I haven't answered? Okay, so the only other last couple things that I wanted to hit on is really who's your team, right? And I think this is a great one for you to field. We've talked about what the medical team can look like, but what else does a team what have you found valuable as far as a team or the support you surround yourself with?
We have a very specific care team. I mean, like very purposeful in that, and we spoke, I mean, with you about that. And I will say that by the nature of, I consider Pink a family extent. Like there is such love and support within Pink, and it is personal for us. That's not just a tagline, but I get support from Pink by helping others, right, and doing this stuff that hopefully improves the quality of life. So that's important to me. But my direct care team is, we have a plan in place where it's like, okay, my husband obviously is a big part of my care team, but there are multiple friends and family members that are in what we call our circle, right? That is a direct circle that says, okay, when we get to this point, we have a plan for everything, and
Yep.
that. I mean, it's a project plan at its finest, which won't happen the way it's supposed to, but it's a plan A, B, and C. But it's important to have those people and understand, have the conversations with those teams. Even our neighbors are involved in our care plan, quite honestly. Like after we spoke, it's like, okay, I need to make sure that if Dave's not home and something happens and an ambulance is called, that they know I have a DNR DNI. Yep. Like making, even though I might have it posted, those kinds of things, we need to make sure that our circle, but also it might not be our immediate circle, but even an extended circle know about, so that our wishes are carried out, my wishes
Yep.
or his wishes are carried out. So family and friends, but they're identified, and we've spoken to them to say, are you on board with helping us on this part of our journey? It will be hard, but we need you if you're able. And having an open dialogue about that with them. And some say yes and some say no, right?
Yep.
Mm-hmm. And that's okay to say no, and we always say that. But and we've had this conversation, the end of life can be a beautiful thing. And for us, I hope it's every intent that it will be. It may not be pretty, we don't know what that's going to look like exactly, but we're confident, and our prayers are that it will be manageable, but we also know spiritually it will be beautiful. So we've tried to put everything in place with the people that are in our hearts, that are willing to be there with us, so that we can put that in a box on a shelf and say, this is my team, and it's family and friends and caregivers, whether that be third-party providers, that we say, okay, I want my husband to hold my hand instead of changing my clothes or giving me a bath, right? Like I try to plan for as much dignity as possible, right? That it's hard to talk about, but it's like, I want him holding my hand. He's still my husband. Yep. I don't want that part falling on him. And so we've talked through those scenarios and said, okay, here's plan A. Financially, we can do this, and we'll pull this lever. And then if we run out there, we'll pull this lever. And we've got those planned arrangements, so to say, and all the way to the point of what's going to be served at the luncheon at the funeral. Yep. You know what I mean? Like, it's like, because that's a gift my husband and I give each other, right? Like, you don't want, and we've had this conversation too, I don't want to make decisions emotionally. And I want to be a part of that decision process that I'm involved in my life. So if I can do that when I'm well, then he knows what I want. I'm confident that he knows that. My care team, which are family and friends and third-party providers, that's all laid out. Then they're probably going to get it right? 90%.
And I think as people go through this process, that changes.
It does.
And so it's not a one and done conversation. Mm-hmm. It's an ongoing goal, so that as your goals and wishes and thoughts on the process change, those are well communicated. It's really all about making sure that people are cared for in the way they want to be cared for.
And it's a hopefully a gift.
It is a gift to arm your team with the knowledge of your wishes, because their job is to carry out your wishes at that point, not to make decisions for you. And that's a very different experience from a caregiver or a team member. Mm-hmm. I would also want to just mention that while we're talking more about the end of life team, people don't need to go through this alone, right? No. I mean, your team might be small at diagnosis, and it might get bigger as you progress.
Yep.
Your team might be a little bit bigger at diagnosis and kind of, trim off the fat a little bit as you get more personal into what we're talking about now. But whoever that is for you, right? I mean, PINCT certainly plays that role for you, or some aspect of that role.
Absolutely, and I think that that's what we hear over and over again, and I know it's true for me personally, is a survivor gets another survivor, right? Like, even though your journeys may be different, you understand at some basic level what it is to walk in those shoes. And I think that at the end of the day is such a basic need once diagnosed, and it's no one wants to be in the club, nobody does, but when you are, there is comfort, there is healing that comes through being together and walking that with someone that gets it. Because let's be honest, people get tired of cancer, your family, your friends, you want to not be in that cancer world, but you are. And there is fatigue, and I know we'll talk about this later, but you want, at least for me, and I know for a lot of us, we don't want that burden to fall on the very people that love us the most, and whether that be PINCT or family or friends or whatever, and you need to realize, as you were saying, which I think is important, you don't want fatigue to happen, and so your team shifts or it changes. And so a couple of people new coming in, because you need to really let someone have a break. Right? And say, okay, go play golf, or go do this, or go take a vacation.
And I think we're going to talk about caregiver burden.
Yes,
and that's
later
exactly
on.
right. It's a big deal that we don't recognize enough. And so we're going to try to put some attention to it and talk through that issue as well. So we kind of talked about your personal team. I just made some notes, right? Who are they? Who are your people? That's really what we're asking, right? And that's support and guidance. That might be caregiving. That might be emotional support. That might be spiritual support. But I would encourage you, who is that for you? And it might be one person, and it might be 12 people. And I just think that's an important, that network is really, really important.
And I think that most people have one person or two people, right? And I think there's a common theme that I'm hearing tonight in every single topic, and it's like, have the conversation. Have the open, brave conversation, no matter what we talked about tonight. So if you've got your person, which is my husband, it's like, we're going to have that conversation. And how do you feel about this person being part of the team? Because you're going to be dealing with them more than me sometimes. So it's like, is that okay with you? Because he might be like, oh yeah, that doesn't work. So I think it's, again, going back to have that open, scary conversation and say, this is going to be hard, but we need to have it. And just have it. And and I will share what that has allowed us to do, that I will share, is I'm able to put those things in a box and compartmentalize it, because we've addressed it, put it on a shelf until we need to pull it out again. And you do, to your point, you need to review stuff no matter where you're at in your plan, but I can put it aside and go live. And that's what I hope people can.
And I would encourage in the context of that, including your medical providers, or one or two of them, the ones that are most involved in your team, because I know Dr. Geetha and we talked the other night about it, that I guarantee you that the more I know about you and your goals and wishes, the better I can treat you. And I know that's true for Dr. Geetha, and I know that's true for radiation. It's true for all of us. Our goal is to treat you the way you want to be treated, right? Not to be paternalistic and tell you what to do, not to judge you in the decisions you make, but to help you make decisions that are right for you. And ultimately, that's what we're doing here tonight, I think, is trying to start that conversation and to give you guys a framework in which to walk through that. And so hopefully with each one of these series, they're different topics, but they're all very much interrelated. And we're going to cover the same topics in multiple ones, because the conversation will flow that way, and that's important. So the things that we have not talked about that also come up in another one, as far as your team members, your surrogate decision makers, right? Your medical power of attorney, your financial power of attorney, who they are. We can talk about who the state will tell us they are if you don't designate. not a bad thing. I mean, there is a legal hierarchy in place if somebody didn't go down that path to designate people. But there's lots of those bits and pieces that are important team members, whether they're in your inner circle or on the periphery,
yeah,
right? But,
absolutely.
so that's my outline. I don't want to cut the conversation short. I want to keep it going. But is there anything that we haven't talked about that you think is important to cover for tonight?
No, I just want to say thank you guys for listening. And I know this is just such a topic, in my opinion, that is, to your point, Clay and Pink has addressed, it's a gap. No one wants to have these conversations. It's not fun. It's heartbreaking. It's sad for not just you, but your family. But it's important, because if we're informed and we make those decisions and we address them, then we have a better quality of life.
Yeah, there's a gap because they're very, very hard conversations.
They are hard
But they are conversations, hopefully we've highlighted a little bit, they're conversations that matter.
That's right.
It's the right thing to do for each individual. It benefits us as a community and a local culture. It's just trying to change the culture around those scary topics is really what we're trying to do here. So.
Yeah, and I would leave with it, and we're going to be covering a lot, and I'll just say this. I will leave with this statement, and then if you'll close us out. But I would say that, we come into this world, and it's an exciting, amazing, celebratory event. And I hope, and not that anyone wants to leave this earth usually, right? But you hope that by preparing and having tough conversations that are bold and brave, that when you get to that point, it can be just as celebratory.
Absolutely.
Right? So that, at the end of the day, is our wish when we hope no one's ever in that situation, but you don't, everyone unfortunately will pass. And cancer is a horrible disease, but hopefully these steps in this series will help you be able to do that.
Yeah,
right?
That's an excellent point. I think our hope is that people can participate in the series, watch the series, whatever it is that at your leisure. This is being recorded, so you can certainly log on and watch this over again. You can watch bits and pieces. But again, it's really helping you define what's important for you, so that the people that are charged with being involved in your care can take great care of you. I'll just leave with a story. To me, there was a very frustrating dichotomy I saw in that when my son was born. Right, we had to have a birth plan. Who do you want in the room? What music do you want playing? What do you want it to be like? What's the temperature? Every aspect they asked us to think about. If you regard death as another birth, we should have that plan in place. Maybe we don't need to move to it. Maybe we do. But I would encourage, I want people to be able to go through absolutely a sad situation and a sad event, but I would love for people to avoid the tragedy of it, right?
Perfect,
yeah. And so I'll just leave it at that. I think, Dr. Geetha, thank you very, very much for your expertise and your involvement. It's been great. Are there any questions that we haven't addressed? Okay. Great.
Great.
Thank you.
This has been great. Thank you, everybody.
So much. Thank you.